Hello everyone. I'm Mohammed Hamama, and welcome to your ASCP preparation camp. In today's video, where we'll be exploring the crucial role of tumor markers in managing specific types of cancer. From bladder to breast and cervical cancer, we will also explore three critical gastrointestinal cancers: colorectal cancer, gastric cancer, and gastrointestinal stromal tumors, GISTs. Tumor markers are increasingly used to assess prognosis, monitor therapy, and detect recurrence. Don't forget to subscribe and hit that notification bell so you never miss an update in your exam prep journey. Also, check out our store, it helps us keep creating great content for you. Bladder cancer. Bladder cancer is a significant concern, affecting around 600,000 Americans, with 74,000 new cases diagnosed each year. Common symptoms include intermittent hematuria, voiding problems, and dysuria, all of which can be early indicators of this disease. Diagnosis typically involves cystoscopic evaluation and cytology of urine cells. Treatment options range from surgical resection and intravesical treatments to radiotherapy, depending on the stage of the cancer. One of the challenges with bladder cancer is the high recurrence rate, with 50 to 70% of patients developing tumor recurrence within 5 years. This necessitates lifelong surveillance. Tumor markers like nuclear matrix proteins, NMPs, play a vital role here. For example, the NMP22 test, an ELISA-based test, is approved for diagnosing and monitoring bladder cancer. Similarly, bladder tumor-associated antigens, BTA, tests are used alongside cystoscopy for patient management. However, current urine tumor markers aren't sensitive enough to replace cystoscopy entirely. They are, however, useful in extending the period between cystoscopies during surveillance. According to the National Comprehensive Cancer Network, NCCN, the use of urinary tumor markers for bladder cancer is optional. They are mainly reserved for the follow-up of patients who have received adjuvant treatment for cancers staged as CTA or CT1. Breast cancer. Breast cancer remains the most common cancer among women worldwide, affecting 10 to 12% of women. Symptoms often include a lump in the breast, nipple changes, discharge, or alterations in skin contour. The diagnosis is usually established through mammography and biopsy. Treatment involves a combination of surgery, radiation, and adjuvant therapy, depending on the stage and type of cancer. Like bladder cancer, breast cancer has a high recurrence rate, with 50 to 70% of patients experiencing a recurrence within 5 years. Serum tumor markers such as CA15-3 and BR27.29 are commonly used for monitoring breast cancer. CEA levels may also be measured, especially in metastatic breast cancer cases. However, these markers aren't reliable for screening or early detection due to their limitations. For prognosis, tissue tumor markers like UPA and PAI-1 are highly validated. Multi-gene profiling tests, such as Oncotype DX and MammaPrint, provide deeper insights into the genetic expression profiles of breast tumors, helping to predict the course of the disease. For therapy prediction, measuring ER and PR is mandatory in all newly diagnosed invasive breast cancer patients. HER2 status is crucial, as HER2-positive patients may benefit from trastuzumab and other targeted therapies. Additionally, the EGFR pathway can be targeted with drugs like lapatinib. For postoperative monitoring, serum markers like CA15-3 and CEA are sometimes used, although their clinical value remains under debate. Only the European Group on Tumor Markers currently recommends routine tumor marker measurement for postoperative surveillance in breast cancer patients. Cervical cancer. Cervical cancer is the fourth most common cancer in women worldwide and is a leading cause of cancer death in developing countries. The primary cause is persistent infection with high-risk human papillomavirus, HPV, strains, particularly types 16 and 18. Prevention is possible through prophylactic vaccination, and widespread screening has successfully decreased both the incidence and mortality of cervical cancer. Most women are asymptomatic, and the disease is often detected only after abnormal cervical cytology is identified during routine screenings. The primary tumor marker for cervical cancer is squamous cell carcinoma antigen, SCCA, especially for squamous cell carcinoma. SCCA levels correlate with tumor stage, size, residual disease post-treatment, and patient survival. Other markers like CEA and CA-125 may have potential utility in adenocarcinoma cases, though their clinical value is still uncertain. Treatment plans are based on the clinical stage and histological type of the disease. Early-stage cervical cancer can be managed with radical hysterectomy and pelvic lymphadenectomy or radiotherapy. Advanced stages may require chemoradiation or neoadjuvant chemotherapy. Currently, no serum tumor markers are recommended for routine clinical use in monitoring cervical cancer patients. Colorectal cancer. Colorectal cancer is a major health concern, ranking as the second leading cause of cancer-related deaths worldwide and in the U.S. It's also the fourth most frequently diagnosed cancer in the U.S. Symptoms often include changes in bowel habits, weight loss, anemia, and blood in the stool. Colorectal cancer develops slowly over time, starting with abnormal cell growth in the colon or rectum. This process can take years, during which the cancer may eventually spread to other parts of the body. Survival rates for colorectal cancer depend heavily on how early the cancer is detected. If caught early, the 5-year survival rate is around 90%. However, if the cancer has spread to nearby lymph nodes, the survival rate drops to about 70%. When the cancer has metastasized to distant parts of the body, the 5-year survival rate is just around 10%. For colorectal cancer, carcinoembryonic antigen, CEA, is a commonly used tumor marker for both diagnosis and monitoring. Diagnosing colorectal cancer typically involves a combination of tests such as fecal occult blood tests (FOBT), colonoscopy, imaging tests like CT scans, biopsy for histological confirmation. Key risk factors include a family history of colorectal cancer, personal history of colon polyps or cancer, inherited genetic syndromes like Lynch syndrome, and advancing age, especially after 50. Treatment options vary depending on the stage and may include surgery to remove the tumor and affected tissue, chemotherapy to kill cancer cells, radiation therapy, targeted therapy to block specific pathways that cancer cells use to grow. Monitoring after treatment is crucial. CEA levels are checked every 3 to 6 months for the first 5 years to detect recurrence early. Imaging tests like CT scans may also be used periodically to ensure the cancer hasn't returned. Early detection significantly improves treatment outcomes and survival rates. It also reduces the risk of complications and helps maintain a better quality of life for patients. Ongoing research aims to develop new, more effective treatments. Current recommendations include regular screening for individuals over 50, genetic testing for those with a family history of colorectal cancer, and consistent monitoring for recurrence after treatment. Gastric cancer. Gastric cancer, or stomach cancer, is relatively rare but remains the second most common type of gastrointestinal cancer worldwide. In the U.S., approximately 25,000 new cases are diagnosed each year. Gastric cancer is often diagnosed at an advanced stage, with more than 60% of cases involving cancer that has spread to nearby lymph nodes or other parts of the body. The 5-year survival rates vary greatly depending on the stage at diagnosis, 65% for localized disease, but less than 5% for those with distant metastases. For gastric cancer, tumor markers like CEA, CA19-9, and AFP are commonly used. However, these markers are not reliable for screening or early diagnosis and are typically elevated in only 20% of early-stage cases. HER2 is a protein that can be overexpressed in some gastric cancers. About 10 to 25% of gastric cancer patients have HER2-positive tumors, which may respond well to treatment with anti-HER2 antibodies. HER2 status should be determined using immunohistochemistry or fluorescent in situ hybridization, FISH, if systemic therapy is considered. Determining HER2 status is crucial for guiding treatment decisions. Patients with HER2-positive tumors may benefit from targeted therapies with anti-HER2 antibodies. Due to the heterogeneous expression of HER2 in gastric cancer, multiple biopsies may be necessary to accurately assess HER2 status. Gastrointestinal stromal tumors, GISTs. GISTs are rare tumors found in the gastrointestinal tract, including the stomach, small bowel, large bowel, esophagus, and omentum. Despite their rarity, GISTs are the most common type of mesenchymal tumor in the gastrointestinal tract, typically affecting middle-aged and older adults. The incidence of GISTs is estimated at 0.68 to 1.5 per 100,000 people in Western countries. Increased awareness since the 1990s has led to more accurate diagnoses of these tumors. More than 95% of GISTs express the KIT protein, also known as CD117 antigen. Mutations in the KIT gene occur in 80 to 85% of GISTs, while mutations in the PDGFRA gene occur in 5 to 10% of cases. Diagnosis of GISTs often involves immunostaining for the KIT protein. However, the presence of KIT protein alone does not confirm a GIST diagnosis, and its absence does not rule it out. Histopathology remains the gold standard for confirming a GIST diagnosis. The treatment landscape for GISTs has improved dramatically with the advent of tyrosine kinase inhibitors like imatinib and sunitinib, which target KIT and PDGFRA. The response to these drugs largely depends on the mutational status of the KIT gene. Before starting treatment with imatinib, KIT and PDGFRA mutational analysis is recommended. This helps determine the likelihood of a positive response to the treatment and guides overall treatment decisions. If you found this helpful, don't keep it to yourself, share it with friends who might benefit. For more insights, grab our ASCP short notes linked below. Have questions or comments? Drop them below, we love hearing from you. Hit that like and subscribe button. Also check our stores. Thanks for watching.